Welcome, everyone, and thank you so much for taking the time to participate in this webinar. This is the third in a series of webinars on the I'm Here approach, and the purpose of the webinars is understanding how best to include and respond to adolescents affected by crises or displacement. I know that it's late in the evening there in Cox's Bazar, where many of you are joining from. So we really appreciate that you've taken this extra time out of your day to learn more about the work that we are doing to respond to the SRH needs of adolescents in Cox's Bazar. As I mentioned, this is the third and final webinar in our series. The goal of the webinar series was to raise awareness within the humanitarian community on how current practice can change to one that is a more deliberate approach that responds to adolescents' context-specific needs, priorities, and assets. So the first webinar in our series took place about a month ago, and that webinar introduced participants to the I'm Here approach and the principles that were underlying the approach. The second webinar, which was 3 weeks ago, shared lessons learned from field implementation of the I'm Here approach in Nigeria and Lebanon. And for today, we wanted to take a closer look at a particular humanitarian response that has very unique contextual factors impacting adolescents' access to programs and services. And I'm sure, as you are all aware, since 2017, the Rohingya refugee response in Cox's Bazar has been one of the fastest growing and largest refugee responses in the world. And although there are very particular challenges for adolescents, there's also been a very strong and concerted effort to meaningfully respond to adolescents' needs from the onset of the crisis. And today we'll hear from 3 colleagues who have been working on adolescent programming in Cox's Bazar, and they will share with you some of the unique challenges that they have encountered, but they will also highlight how humanitarian actors in Cox's Bazar have been at the forefront of adolescent responsive programming, and in particular, responding to the sexual and reproductive health needs of adolescents. First, we will hear from Dr. Nasreen Akhter Romi. Dr. Nasreen has been working as the Senior Reproductive Health Manager and leading SRH programming with IRC Bangladesh since 2018. She holds degrees in an MBBS degree and a degree in public health, and has been very active in the ASRH task force in Cox's Bazar. Next, we will hear from Kabita Islam. Kabita has been working on the refugee response in Cox's Bazar since 2019. She was previously with Partners in Health and Development, and very recently has joined the Bangladeshi government as a program officer in the Department of Women's Affairs. She was also chair of the ASRH task force during her time in Cox's Bazar. And last, we will be hearing more from Partners in Health and Development on their implementation of the I'm Here approach. So PhD has been working with us, Women's Refugee Commission, over the past 6 months to examine current approaches to reaching adolescents in Cox's Bazar, with the goal of having a more intentional approach to outreach, recruitment, and program design. So Asif Sadhuzaman will be presenting. He is presenting also on behalf of Dr. Daniel Hussein, who is unfortunately unable to join us today. But Asif is a research coordinator with PhD, and he has been working on the refugee response in Cox's Bazar for the past 2 years. He holds a master's degree in anthropology, and he has really been at the forefront of our programming over the past 6 months and led much of the qualitative research as part of the I'm Here approach. So I'm really excited to be joined by these wonderful panelists who have such great insight into the work to respond to adolescents' needs. We will have about 15 minutes at the end of our presentations for questions and answers and for discussion. So we encourage all of you to submit questions using the Q&A feature throughout the presentations, and so we'll have time to respond to those at the end if we can't get to them throughout the presentations. And we also encourage you to use the chat feature to get to know who else is here in this virtual Zoom webinar. So feel free to introduce yourselves in the chat, share your name, your organization, and where you are located. It's always good to know who else is here with us. So with that, we will get started, and I'm happy, and sorry, I should introduce myself, I suppose. My name is Julianne. I'm the Senior Advisor for Adolescent Health and Protection at Women's Refugee Commission. And we're also joined by Catherine. Catherine, do you want to introduce yourself?
Sure. Hello, everyone. I'm Catherine Gambier, and I'm a research advisor with the Women's Refugee Commission.
So, all right. So I will hand it over to Dr. Nasreen, and she will be starting us off. Nasreen, please go ahead.
Hi, thank you so much for the opportunity given to IRC Bangladesh. I'm honored to take you through the formation of ASRH task force in Cox's Bazar. So this is the evaluation of adolescent and sexual reproductive health and rights Rohingya refugee response. As Julian have already introduced me, I'm working with IRC right now. So adolescent and sexual and reproductive health rights in Cox's Bazar was an outcome of intensive involvement within ASRH partners. You can see a picture of a session which was organized and facilitated by IWAG ASRH sub-working group back in October 2018. This training was the first catalyst that drove some of us with the participants to participant from the training to think about formation of ASRH task force. Here the most support came from the IWAG ASRH sub-working group members during this journey. So here the formation of ASRH task force was done by the trained participants from three key agencies, I will say UNFPA, IRC, and Save the Children International, then others. And we also had support from Health Sector Coordinator and SRH Working Group Coordinator. Next slide, please. Thank you. So the process for this task force formation was persistence and continuous technical assistance and advocacy with like-minded colleagues from IRC, Save the Children, FHMTI, UNFP, and TDH. Some field-based evidence were also shared on ASRH to different sectors and working groups, including data from health facilities. Data collection, age group of different organizations, including government, were also checked during the journey. We have also checked GRP of 2018, which was not adolescent inclusive, and inclusion of ASRH in the Joint Response Plan for 2019 was done successfully. Next slide, please. So this is just a data showing how data were collected in Cox's Bazar back in 2018. You can see the age group here. The adolescent population has been counted from 12 to 17 years, where 10 to 11 falls in another group and 18 to 19 years fall in another group, which is changed now successfully. Next slide. So I also want to reflect the 2090 GRP objective, which is improve equitable access to and utilization of quality, life-saving and comprehensive primary and secondary health services for crisis-affected population, with special focus on sexual, reproductive, mental, neonatal, child and adolescent health, mental health and psychosocial support, and non-communicable diseases. So ASRH Task Force, you will also be happy to know that ASRH Task Force Technical Point attended Women Deliver Conference advocating for ASRH Task Force back in July 2019. UNFP also started receiving fund for adolescent responsive SRH programming. Next slide. So ASRH Task Force chair started presenting and attending an IWOC ASRH working group meeting virtually. We have started mapping ASRH stakeholder through SRH working group in March 2019, where only 13 organizations responded. Next slide. Okay. So here we have organized TOT, first TOT on ASRH, jointly IRC and UNFPA. Then SRH working group supported the ASRH task force to conduct another TOT where 14 organization was involved with 20 program managers. We have also done interagency facility assessment on adolescent friendly health services. IRC and UNFPA also conducted training on ASRH case management with the midwives. Next slide. So after the formation of ASRH Task Force, our activities of ASRH Task Force was providing technical support on ASRH in humanitarian context, also orienting health professional on adolescent sexual and reproductive health, developing various training package which will be contextualized, generating knowledge through research, advocating to mainstreaming ASRH in this Rohingya response. Next slide, please. So I will take you through the through IRC. Adolescent sexual and reproductive health was not in IRC Bangladesh program. Also age group in register to collect data was below 18 and above 18, which is aligned with government. But in this age group, we 10% of adolescent data used to miss. Next slide. So then we started adopted adolescent inclusive programming. Initially, we have raised fund for capacity building of managers, frontline providers, and as IRC is working different type of facility like women's center, primary healthcare center, health post integrated women's center, IRC have explored that frontline providers need to be sensitized on adolescent responsive programming as well. And we have then funded to train partners, frontline provider as well, because they will be also referring client or patient or beneficiary to frontline health care providers. Next slide. So you can see the picture of adolescent accessing to our facility. So IRC included adolescent in SRH program, which is provided in women's centers. Here the picture is of one of our women's center. IRC revised register book that collect data and changed age group where now 10 to 19 age group is included and no data of adolescent age is missing. IRC also launched adolescent focused health program very recently. IRC have focused on case management adolescent programming rather on policy. While I'm saying rather on policy, we can see that most of the time advocates are working on policy more rather than case management. So throughout this journey, we have also seen that case management is also very important in terms of adolescent, because often adolescent do not access service with the actual reason. So the case manager is very important in that case. So next slide, please. So this is data from our women centers. Here I have taken data from women centers only. You can see there is yellow bar and yellow and orange. So yellow is in yellow data recorded from 18 September to 19 June, where our adolescent who accessed service, the number is 1997. After that, we have trained our frontline providers on June 2019 on adolescent friendly and responsive services. After the training, we have seen drastical increase in number of adolescents who access service from our facility. Here that are recorded till November 20. Next slide. So this is just a picture from our new adolescent focused program. Here, mapping of married and pregnant adolescent was done during this journey. So next slide, please. So thank you so much for your time. I will add one thing in the last is during this process, we have understood that not only the organization, also the individual's willingness is very important to work for any neglected group. Thank you so much.
Thank you so much, Dr. Nasreen, for sharing the background and the history of the ASRH task force, and also how IRC's work has adapted and changed as a result of a lot of the findings from some preliminary assessments from the task force. And I'm sure we'll have some more time for discussion at the end of our presentations. If anyone has questions specifically for Nasreen, please feel free to submit either in the chat or through Q&A, and we'll make sure to get to them at the end during our discussion. So I'm now going to hand it over to Kabita. As I mentioned, Kabita was previously working with Partners in Health and Development for about 2 years, where she led adolescent programming, and she's going to present on PhD's programming targeting adolescent girls and building their capacity to make decisions related to SRH. Kabita, over to you. If you're able to share your screen, I know you're having some internet issues, so hopefully it holds for this. Go ahead.
Okay, thanks, Julian, and thanks, everyone. Okay, I'm sharing my screen. Can you see the slides, Julian?
Yes, we can.
Yep.
Okay. Okay, thank you, everyone. This is Kavita Islam. Thank you, everyone, for giving me the floor. And today I'm going to present you about the Skill Gulf Force program that is being implemented by PSD and supported by UNFPA. I'd like to share the program, our program, the activities, achievement, goals, and objectives and challenges, and how we overcome those challenges. Okay. After the last influx since August 2017, the total Rohingya population became almost 1 million. And out of which 52% of total population is women and girls. And there was no comprehensive study or research to explore the ASRH consequences and distinct needs of adolescent girls before this project. Thereby, UNFPA and PSD sought to establish an in-depth research program, especially a pilot program to explore the existing knowledge, attitude, and practice regarding ASRH. as well as determine the effective mechanism for reducing child marriage and early pregnancy. And for this pilot program, we chose 3 camps from all PhD working area. I would like to inform you that PhD is working in 19 camps out of 36 camps. And the camp we chose for adolescent programming is Camp 1 East, that is located in Utupalong, Camp 3 that is located in Madhuchhora, and Camp 10 in Balkhali. And our objective was to educate 300 unmarried adolescent girls on comprehensive sexual reproductive health, rights and education, gender protection, GBV, through this project. And this will be our output level. And through this education, the girls are believed to have improved skills and capacities to exercise ASRH and access ASRH facilities autonomously. And these girls will be developed as peer educators as well, so that they can teach other neighborhood girls. And ultimately, in the impact level, we would like to see the reduced child marriage and early pregnancy among adolescent girls, and these delayed marriage or delayed pregnancy become the socially accepted norms in the targeted area. Okay, in the first quarter of 2019, a demography survey was conducted by community health worker by PhD, who were trained by ASRH mentors and ASRH program officer. I must mention that community health workers visit household to household for counseling and referring community people to health facility for ASRH and other issues. And so we took the opportunity and collected the demography data through them. However, in PhD working blocks of those 3 camps, we found total 6,439 girls, and we collected demographic data on their education status, caregiver status, marriage, or pregnancy status. Okay, we divided the adolescent girls based on the subgroups. Like very young adolescent, very young adolescent whose age is from 10 to 14 years old, middle adolescents from 15 to 16, and older adolescents 17 to 19 years old. And among total 6,439 girls, we found the very young adolescent girls are the biggest in number than other subgroups. And interestingly, this percentage of literacy was the bigger in number among this group than other subgroups. And the percentage of reading among the total adolescent girls, we found that 8% reading and writing was 12%, reading, writing, speaking was 3%. Well, we conducted this assessment through based on English. They can read, write, or speak English, and those who can't read, write, or speak English was 77%. We choose to assess their literacy based on English because we want to mention that really based on English language, because neither they don't know Bangla and we don't know Burmese. That's why we choose English. And in caregiver status, we saw the percentage of girls having both parents was 75, and 14% girls have only mother, and 5% girls have father, and we found 6% girls unaccompanied. Regarding marital status, we saw that the average age of Rohingya girls for getting married is 16 to 17 years old, and 13% adolescent girls were married during that time. And regarding pregnancy, we saw that married girls with at least one child, or 5% among the married girls. Okay, and the pregnant was 15%, and married adolescent but having no children was 40%, and 9.43% adolescent girls were pregnant with at least one child, and 12% girls had two children, and 1.32% girls had 3 children then. Well, this is the curriculum we determined for the skill girls. We adapted this curriculum from WHO Job 8, Population Council, Youth Participatory Toolkit, and so on. You can see there are total 35 sessions, and from session 1 to 14 are based on social and emotional skill like self-esteem development, trust building, setting personal skill, this type of things. We also want to develop this type of qualities among the girls, as well as we wanted to take some time to build rapport with the girls and create a sense of awareness among them, create a sense of reliance between the mentor and adolescent girls. And that's why we started the session on ASRH issues after the session 15, and you can see at the last the session 35 we kept a practical session demonstration by girls, one session, and on the last session the girls will be given a topic to present or to demonstrate about that topic or that issue before their before her classmates. And yes, this is the curriculum. And we chose the total 300 unmarried adolescent girls who were especially willing to join the program, or who like social gathering, motivated, and their parents are also willing to let them join. Another important criteria to choose them, important criteria was to be the unaccompanied adolescent girls, because they are believed to be more at risk and are also needed to aware on SRH. In 3 camps, we had 3 ASRH learning centers we established and recruited 100 adolescent girls. And we divided 100 adolescent girls into 8 batches comprising 12 or 13 girls. And we conduct session on Sunday, from Sunday to Wednesday. And in each day, 2 batches of girls come, and the next day, the next 2 batches, and the third 2 batches, like consecutively. So a girl comes in the learning center once in a week, and in 1 week, 1 session is completed with all 100 girls. Okay, when before starting the session, the adolescent mentors started collecting baseline data. Baseline data is actually about the sessions, the prior ideas, knowledge, or perceptions of the sessions that is she going to receive that day. And the baseline data is collected by mentors, and she sent it to the ASRH program officer through Kobo, and after that ASRH program officer analyze those data and make a report and submit to the UNFPA team. And I have already described about the SRS sessions. See, life skills like leadership, trust building, networking skill, and regarding SRH issues, menstrual health management, child marriage, early pregnancy, healthy relationship, romantic relationship, this type of the sessions we teach them. There were 8 indicators determined for the skill girls while designing and developing the project. First is ideation, that is existing knowledge and perception of adolescent girls regarding SRHR, and skill, that is ability to apply the knowledge in life related to SRH, and personal autonomy, that is she can decide over her life, especially on marriage or mobility. Subjective norms, how adolescent girl analyze SRH practice in the community, and self-image, how they image their life regarding SRH, intention regarding SRH in their own life and in the community. And in social influence, that is their achieved capacity to influence the family members or community people, and behavior that is healthcare or health-seeking behavior that affects their life. Well, for every session, we set questions based on the indicators. You can see there is an example of questions data that is also baseline data, and the same questions are also used for the assessment after 10 to 12 sessions are done. There is example of session 16 that was about reproductive system. Yes. For example, in ideation, the question was, do you have idea about menstruation and wet dream? And in intention, would you like to learn about male and female reproductive system? Self-image, the question was, do you think a girl like you should know about the male and female reproductive system? And social influence, the question was, if you learn about reproductive system, will you teach your neighboring friends? And behavior was, if you have pain during and in personal autonomy, the question was, can you delay to have sex or get married up to 18 years old? And in subjective norms, do you think knowing about reproductive system of opposite gender is okay? See, these indicator-based questions, when a girl answer yes, we provide her score 1, and if she says no, then we give her 0, and these scores are used to analyze her level of changes in the next level, in the long run. I mean, okay. See, we have both pre-test and post-test. Pre-test is the baseline data collection I have discussed before, and after 10 to 12 sessions are complete, we conduct post-test with the same questions. And due to COVID-19 pandemic, the learning centers were closed for 6 months, and though our assessmenters went to the adolescent girls' household to award them on COVID-19 and other ASRH issues, but our learning centers were closed. That's why we decided to complete all the sessions. Learning centers is now taking the sessions, and sessions are done, but the post-test is going on. That's why I can't show you. Can you hear me, Julian?
Yep, you're clear.
Okay. That's why I'm showing you the data from post-test 1 that was held in January. You can see after the post-test 1 in January, we from that result we divided the girls in 4 categories. That is A, B, C, D. Actually, there are 4 grades. In grade 1A, those girls achieved 80 to 100% score. They belong to grade A, and you can see 35% girls belong to grade A, and 44% girls belong to grade B. For that, she secured 60 to 79% score, and in grade C, you can see 12% girls belong to grade C. Their scores are 40 to 59%, and 9% girls belong to grade D, and their score was 0 to 39%. And yes, and when we compare the result from pre-test and post-test, we saw that the percentage of score for 300 girls in addition was 17.71%, and in post-test was 71.70%. See, you can see the difference in self-image, 63 to 82. The score was for pre-test in intention was 70%. That has been increased in 86 on the post-test, and the pre-test was 58 on social influence, and that has been increased in 66. In skills, the score was 51 and increased 59 to the post test. And personal autonomy, we saw 65%, and that had been increased in 68. And subjective norms was 60, and that increased 77. However, after a few months of our program, we noticed that a number of girls were being dropped out. Then we conducted FGDs with the girls primarily to know about the challenges and barriers, and we found out that community gatekeepers like fathers or elder brothers, some neighbors, religious leaders, or community leaders like machis were discouraging or demotivating to attend the session. They're prohibiting them. That's why we realized that we need to know the community culture and practice in depth, and we also need to sensitize those community people as well. And that's why we conducted community dialogue. We targeted 300 caregivers of the adolescent girls, including fathers, mothers, elder brothers, elder sisters, and also targeted 135 community leaders, those who were responsible for our adolescent girls, where our adolescent girls are, the adolescent where those who were responsible for the blocks where our adolescent girls were living. And we conducted total 54 community dialogues with them with a view to understanding how much his parents or adolescent define childhood, adolescent, or adulthood, and also understand the attitudes of machis or parents on the education of ASRH for adolescent girls, and also the attitudes of machis and parents on marriage and reproductive rights for women and girls, especially on menstruation, marriage, pregnancy, frequent pregnancy, contraceptives for men, women, or girls, or knowing family planning and all SRH problems before marriage, gender roles in the community, and gender-based violence. And we conducted the community dialogue chronologically in every quarter, mostly 2 or 3 topics in one quarter. The approach was FGD because we started with asking questions to and also in order to explore the community knowledge, attitude, and practice regarding the SRH. About SRH for adolescent girls, and after the exploration, and we also try to sensitize them, the community people, on accurate SRH practice for girls. And these are the key findings from our community dialogues. I would like to share. Regarding adolescence, we saw that there was no term exist in the Rohingya community that defines adolescence. That means the transition between childhood to adulthood. In Rohingya community, a girl is child or adult, and they're also divided into two subgroups like Balek that Balek that groups are 12 to 17 years old, and also Zuan, that is 18 to 13 years old. And according to them, they all are marriageable or fertile. Okay, and okay, and once girl gets menstruation, she gets Zuan, that means adult. And she shouldn't go outside the house, and people consider as bad girl if she is visible outside, and according to them they should stay at home. And for adolescent girl, the comprehensive sexuality education for adolescent girls is really unaccepted in the society. Community people think that girls may be perverted if they get those type of education. And early marriage, marriage before 18 years old, also identify yes, those girls get married after 18 years old, or stay unmarried up to 18 years old. Community people think they are spoiled or characterless, or she might have a problem or fault in her health, or in and as if she is not suitable for marriage. And community people also think that the girls should get married at an early age, also get pregnant immediately after marriage, because they think that girls keeps mm, fertile at an early age, and there is highly unmet need of family planning, because uh, um, need of family planning we can see, because in our chosen 300 adolescent girls, when we collected data from them, we saw that the average number of siblings was 6.8% from our 300 adolescent girls. And yes, in family planning, they don't have a proper knowledge about family planning or method, and they think the family planning is adopting family planning method is an act of sin, and men don't like to use contraceptives, especially the condom they don't like. But those who use contraceptives, among them, Depo-Provera is mostly used in camp, told by Majis. And community people think that they should have babies as much as they can, because they have lost a lot of lives during the casualties in Myanmar, and even if his daughter may die to give birth a number of babies, because it is Almighty's wish. Yes. And myths, those men go through tubectomy, gets important, and wives leave them. Those girls remain unmarried until 18. She must have some kind of sickness. This type of myths are existing in the community level. And regarding gender roles, we found out that girls, according to the community people, girls should stay at home and do household chores, are not allowed to work outside. After marriage, an ideal girl should give birth to children immediately and take care of husband, in-laws, parents, and children. And gender-based violence, we found that it is quite normal. A husband can beat his wife if she does any mistake or negligence in household chores or talk with other men. If a girl gets victim of violence, that is the girl's fault in some extent. However, after exploring all these barriers, challenges, we and this and also the malpractices, existing malpractices from the community, we realized that we need to implement our program with 360-degree approach. Besides comprehensive sexuality education for adolescent girls, we started community ASRH leadership program with caregivers in the family level, to sensitize the family level, and to sensitize the community level, we arrange training for community health workers and for RAG. RAG, that is Reproductive Health Awareness Group, is a signature program of PhD that consists of community leaders, religious leaders, teachers, TBS. We started sensitizing them, and also sensitizing camp in charge and the service providers, frontline service providers of health post. And in social structure, we started sensitizing health sector, research subsector, community health worker, and also we have health advisory group in Cox's Bazar, that is ASRH task force, and our previous panelist, Dr. Nasrin Apu, has discussed about that organization before, and she also explained, she also discussed how ASRH task force is trying to highlight ASRH in the existing social structure. And yes, after implementing or engaging all tiers of the community society, now we found that our programs is going quite smoothly, and adolescent girls are attending sessions with less barriers now. Well, thank you all for hearing me with patience. If you have any question, you may ask.
Thank you so much, Kavita. Wow, even though I've learned about this program before through our work together, it was great hearing so much more about it. And I'm just continuously impressed with the great work that PhD is doing. So thank you. And we do have a few questions, but I think we'll save them until the end because we have one more presentation and I want to make sure we give enough time for Asif to present on the continued work that PhD is doing to reach more adolescents with your wonderful programming. So Asif, I'm going to go ahead and share your presentation, and please one moment. All right, and please go ahead and get started.
Thank you, Julian. I'm Akem Jaman Asif. On behalf of Dr. Daniel, I'm here to present. So first of all, would like to start with thanks to WRC and PhD team to create this platform, and all the respected participants and panelists for participating in this webinar. Today, I am going to share our experience on the application of IMHAR approach on behalf of PhD, which was used for the project innovative approaches to reaching isolated adolescents, girls in Cox's Bazar with critical gender-based violence, sexual reproductive health, and health information and services program. Let me share a few words about IMHAR approach. IMHAR approach is an effective methods. First slide, Julian. IMHAR approach is an effective method that is assist implementing partners to connect the vulnerable adolescent and supports stakeholders. It helps the stakeholders in being responsible to adolescent safety, health, and well-being. So next slide, please, Julian. Yes, the goal of IMHAR approach is to find out the challenges and mitigation of the crisis people where we worked along with the same objectives by using the approach and worked closely to develop to the understanding with adolescents to identifying their needs and priorities to reach the services like gender-based balance and sexual reproductive health. So we have followed to develop the intimacy with them where they feel comfortable to share and listen. Moreover, we targeted to segregated the findings identified from the inquiry and designed plan and recommend the areas that can develop throughout the program. We have kept it in our program objectives that present pandemic situation and its impact can influence the access to programs, information and services for Rohingya adolescents. So next slide, please, Julian. Yes, study overview. As we know, adolescent is the most isolated part of the population, which is consistently overlooked by humanitarian actors. And that's why our targeted population is the vulnerable Rohingya adolescent boys and girls, and they are aged between 10 to 19. To achieve our program objectives, we identified and engaged adolescents to get an in-depth understanding of how barriers affect their access to sexual reproductive health and gender-based violence services using WRC's IMHAR approach. IMHAR approach provides a set of tools that helps us to know the key resources and services existed in this area, a demographic profile of adolescents and their needs and priorities. And the location of the Camp 14 Block E is remote and hilly, and it's very hard to reach for the Rohingya people to get access to any kind of services provided by NGOs and other organizations. And that's why the Camp 14 Block E was chosen to evaluate the whole situation of adolescents, especially the vulnerable girls and boys. Next slide. Yes. Mm, Now I am here approach. Now let's talk about I am here approach, which has three pillars. The first one is find them. Second one, listen to them, and finally design with them. The pillar of find them includes service mapping and adolescent mapping. These two steps help us understand what resources exist in a community and provide insight of demographic profile of adolescents in the community. Adolescent mapping includes boy matrix and girl roster developed by Population Council, which a short household survey that asks very basic questions about adolescent, like age, education status, and marital status, and so on. The second pillar, listen to them, is divided into two steps. The number one is participatory activities and asset building exercise. First, we conducted a participatory ranking methodology, which is a mixed method approach to assess the different needs of different subgroups of adolescents. Then asset building exercise invites participants to consider what concrete information, skill, relationship, and other assets adolescents should have, and by what age in order to make a safe transition to adulthood. Okay, the third, no, the yes, the third pillar, design with them, mainly involves adolescent in program design, implementation, monitoring, and evaluation. Real-time monitoring supports program staff to improve retention, and adolescent benchmark uh, provide a framework for evaluating how programming has built adolescents' strength and assets. Okay, the next one, Julian. Thank you. Yes. Why does this approach fit for the Rohingya context? And so the I am here approach is suitable in the Rohingya context because we find this approach give importance and deeply prioritize and the adolescent safety and well-being aside from younger children and the older women. It considers adolescent as a heterogeneous groups, as adolescents with different demographic characteristics, where they can opportunities to explain and share their different needs and priorities. Um, and it is designed to implement a program to address those needs and priorities. Though it was originally designed for girls, and it is expanded by including boys to get overall idea about the adolescents. The tools of this approach help to know the challenges which prevent adolescents to attend program and follow-up session. Next slide, Julian. Yes. So this is our findings which we got from service mapping and adolescent mapping. So from service mapping, we found that most of service were not adolescent friendly, and only few were adolescent friendly. From the breakdown of key services in terms of key services in terms of adolescent friendly status, we can see that health facilities and adolescent center in that camp are not adolescent friendly at all. But the case of nutrition center and a girls only space are absolutely converts. On the other hand, more than 30% of schools fulfill the adolescent friendly criteria. And nevertheless, less than 20% of wash facilities are able to meet those criteria. From adolescent mapping, we found that lots of girls from age group 13 to 16 and 17 to 19 never went to school, while comparatively more boys went to school than girls. From boy metrics, we discovered that boys from age group 17 to 19 are more engaged with income than the other two groups. Next slide, Julian. Yes. From girl rooster, we found that less than half of adolescent girls need someone to go outside from the house, and according to the Rohingya context, our assumption of child marriage, and according to the Rohingya context, our assumption of child marriage did not match with the reality, where we found very less adolescents are married. Among those married girls, about most of them is 19. Besides the status of adolescents in program or NGO services represents adolescent girls had less access to participated less than boys. Okay, next slide. Yes. Participatory activities. We exercised participatory activities with the Rohingya adolescents. At first, we selected some subgroups that contained 8 to 12 participants according to their age, gender, marital status, education, and program participation for participatory ranking methodology. In this activity, we also conducted in-depth interview with two disabled adolescent girls. So next slide, Julian. Yes. So this is our PRM. This picture depicts when we conducted the PRM. This is this picture for one is for girls and one is for boys, and the another one is indicates in the ranking ranking of their various. In PRM session, we asked about the challenges or risk that girls and boys of their age faced in that camp. After listing all those challenges, They ranked those on the scale of most important to least important. From PRM sessions of 12 groups, 45 unique challenges were identified. Next slide. Julian, next slide, please. Yes. From the ranks of challenges that 12 groups created, and these 10 challenges were identified as most important, and the key challenges were no health facilities in the block, intimate partner violence, school is far, and no female doctor, and others. The rank of challenges created by only girls group precedence the mentioned 5 things like no female doctor, dark toilet facility, menstrual hygiene materials, and so on. And from the ranks of boys groups, the 5 most challenges were no adolescent center, anxiety about wet dreams, waiting in line to fetch water, dowry, and corporal punishment in school. So next slide, please. Yes. In asset building exercise, we selected overall 25 assets from groups of adolescents based on their age, gender, marital status, and program participation. Those assets covered 6 domains, which are participation, participants that address decision making and representation in public and public and within household, and access of rights and access to entertainments. Health that includes support healthy behaviors and reduction in risk and use of health services. The third one is safety, that includes promote physical security at home, in institutional settings and in public space. Education indicators contribute to concrete skills buildings and access to school or alternative learning and environment. Social, that relates to features of relationship with self, peers, and adults. Economic, that relates to earning, savings, or managing money. Next slide. Yes. We completed the first 2 pillars of IMAR approach, and this is totally new approach to us, and now we are looking forward to implement a program which will help adolescents to build the necessary assets and overcome the challenges that were identified by Rohingya adolescents, and we also want to include more of those adolescents who are in vulnerable positions in this program, and we will evaluate how the implemented program helps the adolescents of Rohingya community to fulfill their needs and priorities. So next slide. And thank you everyone for being here, and that's all from today from my side. Thank you.
Thank you so much, Asif, for this wonderful presentation. I've seen that there are some questions coming in, and Catherine, I will hand it over to you to moderate any Q&A or other questions we may have for the discussion.
Great. Thank you, Julianne. And thank you so much to all the presenters. It was really great to hear from all of you, and just thank you so much for all of the work that you do and your respective colleagues and teams to meet the needs and priorities of adolescents in Cox's Bazar. And I know many of our colleagues online are also working in Cox's Bazar as well. So just wanted to acknowledge your great work. There were a few questions for Kavita, and thank you, Kavita, for responding to a few of them. I think, we also wanted to open a similar question regarding COVID-19, which has been on many of our minds and affected, I think, all of our work over the past 9 months. Kavita, you describe some of the adaptations and that you've made regarding the adolescent sexual and reproductive health learning centers, noting that they've been closed for 6 months due to COVID-19. And your mentors from the program have also disseminated information and talked adolescent girls regarding the COVID-19 etiquettes and symptoms and referral mechanisms. I'm wondering if our colleague from IRC, Nesreen, could also describe some of the adaptations you may have made to your programming based on the COVID-19 context.
Thank you so much, Catherine, for the questions. During COVID, I will say, like, when we have seen the outbreak in other countries before coming in this in Bangladesh, we have taken some preparatory measures like inside the organization, like we have procured PPE for our provider and also the volunteers who are from community. Though after the pandemic attacked in Bangladesh, volunteers were not too much engaged in any activity because of local government. But I will also say, like, we used to do adolescent session and women session, which was also stopped because local government, they don't wanted any gathering during those days. And I have seen a drastical decrease in accessing service during COVID, which for me, I felt like it was not really good for the women and girls who stayed in the community, because most of them have must have faced intimate partner violence or domestic violence. I have seen there was no survivors accessing service. That doesn't mean survivors were not there in the community, but and our WP team have assessed in the community in their way and found like domestic violence have been increased during COVID actually. And another measure we have taken in our women centers, as I said, IRC have different type of facility. Like primary healthcare centers are traditional healthcare center where measure for COVID were taken, but we also had our women center, which is not a traditional health facility, but we have taken measure over there with our limited resources. I mean, limited human resources. One more initiative we have taken is in the middle of the pandemic, we have started doing RCCE in the community. We have raised awareness on how to take precaution on COVID in the community, rather doing any gathering. Thank you so much.
Thank you, Dr. Nasreen. I'm also, as a follow-up question, given the difficulty of community members, particularly adolescents, reaching health facilities or women's friendly safe spaces and so on, due to COVID-19 restrictions. And this is a question for all of the presenters. Either given your work within your organizations, or what you've heard of in Cox's Bazar more broadly that's being implemented by others. What have been some innovative strategies or approaches to reaching adolescents in non-traditional spaces?
So in non-traditional spaces like women-friendly space, right? So actually, we didn't take any different strategy, but I will say we had sessions, but in a in a different manner, like a small gathering. Earlier, the gathering used to be 20 women and girls. So when I'm saying women and girls, it is not a combined sessions. We used to take separate, like women and girls separate. So during COVID, we have done this with maybe 5 to 10 participants, also providing them the mask if someone have came without mask in the facility. And also, like as I said, we have taken some measures in the entrance of the traditional non-health facility. In the entrance, we had screening with the thermoflash and few guiding questions, which was circulated through health sector to screen or to differentiate COVID and non-COVID. So we had those questions, and we have trained our the screener on those questions and how to separate COVID and non-COVID. So if there is any suspected COVID, we have provided full PPE to that patient or that beneficiary, and we didn't the good strategy we have taken is we didn't send that suspected COVID beneficiary or client to any health facility before serving them for what they have came for. For example, if a woman or a girl have came to a women's center, that means there must be something which is not for COVID, right? Because we were not providing COVID services. Some of them came for family planning service, STI, or maybe a survivor. But what we have assured is we provide the service that the beneficiary or client came for, and then we refer the client or beneficiary to the place where the COVID treatment will be provided. So during this process, we also had identified an isolation corner where the suspected COVID or confirmed COVID patient or beneficiary was kept till the service were provided to that beneficiary. And while the pathway was very much oriented to all provider or all service provider and staff in the facility, so that everyone knows what to do in those cases. If the beneficiary have come to case worker, they will be bringing the case worker in with the PPE that was provided for them, and then after providing the service, the cleaner will be disinfecting the isolation corner. So the measure was taken in that way.
Thank you so much, Dr. Nasreen, for sharing. I realize that it's over time, but if others are able to stay on for another few minutes or so, we have a great question that was shared by Farzana Sultana that I'd like to direct towards Asif. She writes, Asif, all the best on your new programming. Although participatory program designing and monitoring is not new in Bangladesh, it is definitely new when you're applying this approach among the Rohingya adolescent girls and boys. What are the challenges you are predicting during the implementation of this program?
Yes, thank you, Catherine. Thanks for asking. Acceptance and support of the community people on the Rohingya context can be a challenge where we will adapt different strategy to overcome the changes.
Thank you so much for sharing.
Yeah, which is like a courtier session, individual awareness session, door-to-door awareness session, or rag meeting, and Maji meeting also. So this is the way to overcome these challenges.
Thank you so much. And Kabita also shared the importance of understanding the individuals, the gatekeepers in adolescent girls' lives and those who are important decision makers in adolescent girls' life, and understanding the heterogeneity of adolescents themselves as well. And I think that's one of the key components of the I'm Here approach is looking at all the diversity of adolescent girls and tailoring programming specific to these different subgroups of girls and understanding that the needs of an adolescent, a 10-year-old adolescent girl in school is very different from one who is 18 years old and married and out of school. And it's of course important to look at the socioecological model and understanding, not only engaging with the adolescent girl or adolescent boy for himself, but also engaging with other community members, with parents and Majis in programming. So yeah, thank you so much, everyone. I don't see any. I think all of the other questions in the chat may have been answered, and we'll certainly follow up with everyone with the recording link. Julianne has also shared a link to the I'm Here Playbook, which is an online platform that provides guidance and downloadable tools regarding the I'm Here approach. You can also reach out to us at the Women's Refugee Commission if you have any questions about that guidance and those tools. Thank you everyone for joining, and enjoy the rest of your evening or the rest of your week.
Yes, thank you, Catherine. Thank you, Julian, and thank you, Nasrina Apu, Kavita Apu also. Thank you.
Thank you, everyone. Take care.
Thank you.
Bye.
Bye.